All right, guys, good morning. What I've done is to sort of make it in questions, and then we can discuss each questions, and I wanted to discuss some salient topics. As far as score is concerned, acute limb ischemia is something which will be asked for your board exam too, and some clinical cards are also there in order to make sure that we get it. Does it work? Does this work? Anybody knows? Okay, we'll do it. That's okay. So it won't work. I move it on. That's okay. No
Maybe
worries.
batteries are not there.
No.
Cost cutting,
No, no worries. Okay, who wants to take the first one? We can start from the front. Brooks, you want to take this one?
Oh, you want me to read it?
Yeah, read it, and then we'll go over the options, and we'll go over the thought process of answering this question and what are the salient clinical points that we can learn from it.
A 67-year-old woman with a history of bilateral lower leg breast pain and 35-year smoking history presents to the ED with severe left calf pain for 3 hours duration. She has markedly diminished popliteal, DP, and PT pulses. Motor function is intact, but she has paresthesia of the left lower leg with absence of sensation to the left toes. Capillary refill of the toes is delayed. In addition to IV fluids and analgesia, the next step in the management of this patient should include systemic thrombolytic therapy, 100% oxygen via rebreather mask, IV heparin and angiography, or emergent open bypass for revascularization.
What would you take?
So, she definitely needs heparin.
Okay.
I'm not sure, I guess, angiography, in this case, we would want to do some imaging with it again.
So the question asks about the next step in the management. Invariably, I would have probably put on an exam. If I was going to pick, I was going to pick IV heparin. The answer here is IV heparin and geography, but I would have picked only IV heparin as my answer. Since this is talking about a next step in management, both are okay. I don't think that in exam they're going to ask you like this. This is a particular score way of asking things. Systemic thrombolytic therapy is not indicated in any limb ischemia. 100% oxygen doesn't do anything for the limb. IV heparin with angiography is something that we have asked. And emergent open bypass for revascularization is not an option here. One, this is a acute limb ischemia. This is not a chronic limb ischemia. The symptoms are only for 3 hours. And second, you almost never do an emergent bypass unless it's a trauma, without any sort of diagnostic workup or any sort of imaging workup. That trauma is probably the only situation in which you can do an emergent bypass without any imaging. Few of the things that you want to make sure, what they are asking to is acute limb ischemia. This is something that everybody should know. They won't ask you the category of ischemia in exam, but this is something that every practicing vascular surgeon or general surgeon should know. When we talk about a category 2 ischemia, we most of the time talk about it. Category 2A is something with sensory loss. It can be minimal sensory loss. It doesn't have to be the whole foot is numb. If the whole foot is numb, it's pretty advanced. We're talking about minimal sensory loss. Somebody who's got a little bit of decreased sensation compared to the other foot is considered a minimal sensory loss. And they should have no motor deficit. Zero motor deficit with minimum sensory loss constitute as a 2A ischemia. And a 2A ischemia should be promptly revascularized. 2B ischemia, what most of the time is under-characterized or appreciated is a 2B ischemia in which you have a mild muscle weakness. You go into the patient room, you ask them to wiggle their toes, they do a little bit of this, and you say, you know what, motor intact. No, motor is not intact. They already have decreased ischemia, they are already in 2B ischemia, and if they are in 2B ischemia, most of the time they will have, if you don't revascularize them in the next 24 hours, they will go down the path of non-limb salvage. Now, irreversible ischemia, maybe in your lifetime you'll see 1 or 2 cases. Most of the time you guys see cases of irreversible ischemia which are very advanced, and then you look at your foot from a distance and you know this is not reversible or this is completely gone. But one thing which is important there, right there in the muscle weakness column, is rigor. If you have rigor, if your limb is completely contracted, you go into the room, and that's classical of old people in MICU who have been laying down for a while and nobody has checked their feet for a while, and all of a sudden you get called because one foot is colder than the other. You go in and the foot is in rigor essentially. The other foot is completely flaccid, yet you can move their ankle, but if you try to move the ankle, it's completely stiff. That foot is gone. There's no point in trying to do anything. That leg is gone. Anyways, if you also notice in the Doppler signal, because this is relevant to your clinical practice, if you look at the arterial signal, except for the viable category, there is no arterial signal in any of the other categories. So 2A, 2B, or 3, there will be no Doppler signal. And a Doppler signal, 0 Doppler signal means you have an ABI of 0. Now, if you are, another differentiating point is that you will have some venous Doppler signal in 2A and 2B. And if you are confusing the venous Doppler signal from an arterial Doppler signal, you might categorize them wrong. For example, if you assess the patient and you tell me that this patient has so and so and so, and I ask you a simple question, and that's what in my mind, this is what I'm following. If you ever call me at night, but I ask you a simple question is, are they motor intact, are they sensory intact? Because I'm trying to figure out whether they are 2A or 2B ischemia. The second question I ask is, do they have a Doppler signal? If you say yes, they have a Doppler signal, means they are not that threatened. If they have 0 Doppler signal, means they are threatened, they gotta be revascularized. So this is important. This is just 2 important points for you guys to remember. A couple of salient points. If you have an acute ischemia, almost every time it's going to be because of a thrombus problem, because of an embolus problem. A thrombosis is a de novo clotting of the blood vessel, means it did not originate from somewhere else and lodged there. An embolus is it originated somewhere else and lodged in the blood vessel. So for a thrombus to happen, for example, if you have an MI, it's essentially a thrombosis of the coronary vessel, which causes in addition to multiple other things, the thrombosis of the coronary vessel is what causes a major MI, in which you have an underlying plaque, and that plaque ruptures and causes thrombosis of the vessel right here. So you have an underlying disease in the common femoral, in the iliacs, or in the SFA, or in the popliteal, and the plaque ruptures and causes thrombosis. Embolus versus, we're going to talk about these embolus questions too. This is just because the next questions are going to deal with this. Embolus is it started somewhere else. You might still have diseased blood vessel. And how to differentiate between those two, we're going to go over some questions, and from point to point, once we discuss the topics, once we discuss the clinical scenarios, you will be able to better appreciate what's going on. Initial management is always going to be heparin drip. Initial management is going to be some sort of imaging, or if it is simple, plain, and it is screaming out that this is an embolus, then take them to the operating room. For example, simple cases of cardiac embolus, and there are questions in it. In clinical practice, you just take them to the operating room. Sometimes we do get angiograms, CT angiogram, because it's easier to get, but that's not the board answer. Okay. Workup, we're going to talk about that. In the next some questions, you can get a CT angiogram as your beginning test, or you can get an ultrasound. Almost always an ultrasound in acute limb ischemia is not an option. It's not the right option. It doesn't give you much unless the CT scan is broken or they don't have a CT scanner. And then treatment option is something that we're going to diverge into as we move ahead. Treatment option is of course going to be thrombectomy or embolectomy, and we're going to go over the differences between thrombectomy and embolectomy, and so on and so forth. I'll just read out the next question and we'll go over it. This is a 56-year-old male with a history of left lower extremity SFA stent. Just reading that, you know that there is some underlying disease. This is not a first-timer. Present to the emergency room with a cool left extremity with absent DP, PT, Doppler signal. So you know his limb is threatened. It's not viable. And this is acute. Motor and sensory are intact with poor capillary refill. The right lower extremity is normal. The patient is admitted to ICU after angiogram confirms an SFA thrombosis. So this is essentially an instant thrombosis because there was a previous SFA stent. Another reason that this is a thrombosis and not an embolus does not lodge, normally it does not lodge in SFA. They're not going to give you an outlier for vascular questions. SFA, an embolus lodges at the areas of bifurcation where the artery, if those guys who have done a common femoral exposure are always going to show you guys that the common femoral artery narrows down to SFA and profunda. That's where you identify the branching point. If you identify just the SFA, you just have to dig deeper to identify profunda because the caliper changes from a big vessel to a small vessel. Because the caliper changes to a big vessel to a small vessel, any branching point, that's where the embolus will get lodged. Usually it doesn't lodge in the SFA. It will lodge into the common femoral artery. And an Infeon catheter was placed for thrombolysis. A few hours later, he has Doppler signal. So they put an Infeon catheter in and it resolved the thrombus because you have a Doppler signal in the left PT, DP. But he reports severe leg pain and pain on dorsiflexor. His calf is tight and he has decreased sensation in the foot. In addition to discontinuing the thrombolytic therapy, the next best step in management of this patient is, what's the diagnosis, Albert? Compartment syndrome. Compartment syndrome is a clinical diagnosis. When they give you pain on dorsiflexion, decreased sensation in the foot, you do not need any further tests to confirm it. In a relevant clinical scenario, this is compartment syndrome until proven otherwise. Okay? What will you pick as an answer? B. A compartment syndrome, any sort of answer in the next best step in management in a compartment syndrome is going to be fasciotomies. Why are they doing an intraoperative angiogram? Every time you stop thrombolytics, you want to check an intraoperative angiogram to see if you have perfused the lower extremity or not. But if you have a diagnosis of compartment syndrome, it is going to be 4-quadrant fasciotomy. Another important point. Actually, the score questions are improved a lot when I did it as a resident. Another very important point is the patient has Doppler signals in the foot. So this is, people confuse sometimes if this is ischemia, or they expect that in a compartment syndrome you're going to have no pulses in the foot. That's not the case. Okay, so you can have actually even palpable pulses in the foot because, and we're going to go over it, because I'll tell you the rationale for it, and never be confused that if you have a palpable pulse, it cannot be a compartment syndrome. What's going on here? The muscle is trying to swell because of reperfusion injury. Almost every time, every one of you who has done a bypass with us, you go in to see the patient post-op day 1, guess what? Their leg is swollen and it's tight. Why? Because of reperfusion injury of a ischemic, chronically ischemic leg. Almost every time we revascularize somebody, they have reperfusion, some sort of reperfusion injury. It is more common in people who had normal circulation to begin with because they were profoundly ischemic because of lack of collateral flow, and this is more common in people who have prolonged ischemia. And the number that you are looking for is 6 hours for prolonged ischemia. Just to sort of reiterate compartments, and this is basically they are checking compartment pressures, and we're going to go over this too. I think as a resident you should know, and sometimes you will be asked or you will be dealing with a situation in which you will be checking a compartment pressure. This is a leg and it has 4 compartments, an anterior compartment and a lateral compartment, superficial posterior compartment, and the deep posterior compartment. You cannot get to the deep posterior compartment until you take the soleus off the posterior surface of the tibia. You have to dissect that muscle off, the attachment off the posterior surface of the tibia, then you will reach the deep posterior compartment. Otherwise, you would not reach the deep posterior compartment. Again, those of you who have done these cases with us, I always show you guys to try to feel for the septum between the anterior and the lateral compartment. Make your incision right at the divot where that the septum is. in the skin and then go down to the fascia and then open up the fascia on the anterior compartment and open up the fascia on the lateral compartment to do an enterolateral fasciotomy, and posteriorly you make an incision right on the medial aspect of the leg and go down to the fascia and take the fascia down. That will be your superficial posterior compartment, and then you have to take the soleus down from the back of your tibia, and that will be the deep posterior compartment for you. This is a needle called a Stryker needle. Most of the general surgery residents do not know how to use it. I don't know how to use it. But this is a very neat equipment, a handheld equipment that gives you a compartment pressure. Where are you going to check compartment pressure? The compartment pressure will be checked in a situation in which your diagnosis is questionable. You're not sure, this is not the perfect clinical scenario for you to diagnose clinical compartment syndrome. Everything doesn't match up, but you are still considering a diagnosis of compartment syndrome. In that case, you can check pressures in the leg. For example, an old guy who's on Coumadin comes in after a fall, they've got a subcutaneous hematoma, looks like tense to you, but the compartment might be okay. You're not sure about that. So you can use some sort of needle. What I have done in the past and what can be easily done is wherever there is an A-line setup, you can take your 18 gauge angiocap needle, get an A-line set up, connect it to the monitor, put your needle inside the muscle. What you want to do is, because it will occlude the lumen of the needle as you are pushing your needle in, what you want to do is just tap it to let some water run over it to clear the lumen, and then pull it back by a millimeter, and then it will give you a correct compartment pressure. Again, suspected compartment syndrome. This is actually a good. Sort of a flow sheet. If you have an unequivocally positive clinical finding, fasciotomy. Idiot. That is, do not divulge into checking compartment pressure in exam or in real life situation. If you are thinking about it, this is a terrible problem. If you're thinking about it, do it. If the patient is not alert, they are unreliable, you don't know their exam, you can't even reach a clinical diagnosis because they're intubated. They are polytrauma victim, you are not sure whether their compartment is soft, somebody felt their legs and they think the compartment are pretty tight. And inconclusive clinical finding, then check a compartment pressure. If you check a compartment pressure, check it in multiple compartments, don't check it in one compartment. If it is greater than 30 millimeter of Hg, and this number is sort of there is difference of opinion between these numbers. Some people say if your compartment pressure is 20 millimeter of Hg below your diastolic pressure, that is diagnostic. For example, if your diastolic pressure is 40 and your compartment pressure is, if your diastolic pressure is 60 and your compartment pressure is 40 and above, you got to do a fasciotomy. Some people say the difference has to be 30. The number that I go by, which I keep in mind, is about 30. If your compartment pressure is greater than 30 and you are thinking about compartment syndrome for whatever reason, because there has to be a clinical scenario, nobody will think that I have compartment syndrome standing here. So there has to be some concern that has generated for you to check this pressure. And if your compartment pressure is greater than 30, in that clinical scenario, I would go with the 4-quadrant fasciotomy. If you have a compartment pressure which is less than 30, then you have a couple of options. One, you can continue to follow it, and at some point, if the patient declares itself and the clinical diagnosis is confirmed, go ahead, this is a acute compartment syndrome. If the pressure is less than 30, you can continue to monitor it and keep following this loop. If the pressure becomes greater than 30 at some point, then you can go ahead and move with the fasciotomy. Again, going back to my original point about having pulses, normal mean arterial pressure in the leg runs about 60, and systolic pressure will be about 100 and maybe 30. If somebody has a compartment pressure of about 30, do you think it's going to impede their arterial flow? It will impede the arterial flow at a tissue circulation level. Why? Because the tissue perfusion pressure at the level of muscle and the capillaries is about 40 is considered a normal number. So you can imagine as far as like numbness is concerned, or perineurium or whatever, those small blood vessels around the nerves that are feeding the nerves, And the microcirculation will be impaired, but your macrocirculation, you might still have a palpable pulse in the foot and still having an ischemic process within the compartment. Something to keep that in mind, just simple physiology. Compartment fasciotomy, we talked about that, how you're going to do these fasciotomy. Again, a board answer is to perform a complete fasciotomy. Sometimes we do in vascular surgery, do preemptive small fasciotomy. Some of you guys have done that with me. Those are mainly preemptive fasciotomy. We don't have a diagnosis of compartment syndrome. On exam, on board, please do not do mini fasciotomies. Every fasciotomy has to be 4-quadrant and has to be complete. Means the whole leg has to be flayed open. And every compartment has to be opened up. And they cannot be, skin cannot be closed after that. Okay. Next question. All right. A non-ambulatory nursing home patient presents with 1 week of persistent right foot pain. She has been treated medically for her pain and now presents with exacerbation of her pain. She has a palpable femoral pulse and no signals distally, including in her feet and her lower extremity is cold and demonstrates severe mottling of the toes. She has no motor or sensory function in her ankle and foot. What is the most appropriate next step in therapy? What is the diagnosis here? It's a class 3 acute ischemia. It's essentially a missed ischemia that happened about a week ago. She presented with severe pain about a week ago. Something changed 1 week ago. Okay, she had severe ischemia. It was missed. We did not pay attention to it. And now she's here with class 3 non-reversible ischemia with severe mottling of the toes, with no sensory, no motor function whatsoever. What is another key point in this patient, which will be, again, you will face this in the real life scenario too. Same exact scenario. Non-ambulatory. Okay. What should be your treatment option? Who's going to pick? D, above the knee amputation. Above the knee amputation is probably the most definitive amputation that we can offer a patient. What sort of vascular exam is going to make you happy that it's enough for above the knee amputation? Palpable femoral pulse. If there is no palpable femoral pulse, what you going to do? There is no palpable femoral pulse. You don't know if the profunda is open or not, through collaterals or not. Okay, wrong answer. For above the knee amputation, no workup is required if there is no palpable femoral pulse and no endovascular reintervention is required. That's the board answer. Doesn't matter what you practice. If you are considering an above the knee amputation, you can amputate somebody above the knee if they have no palpable femoral pulse. If somebody has an aorta bifemoral bypass and their lymph goes down, means there is no palpable femoral pulse and they are a candidate for above the knee amputation, go ahead. It's okay. Most of the time it's going to heal. Actually, most of the time, like 80% of the time, there will be no problem in healing. And above the knee amputation is can heal from collaterals in an absence of a femoral pulse.
Do you go higher?
No, I go like a mid. In that scenario, if it's an acute ischemia and I felt like there is not much collateral, then I will go higher. Yeah. If I feel like this is not an acute limb ischemia and there is no femoral palpable pulse, but there is chronic collateral, then I can stay low too, in a low AK. What is the diagnostic? And again, I'm trying to tell you the board answers and what the general surgeon should know about. And this is true. I practice these things in this way. What is the clinical exam? What is required for healing a BKA?
What's required or what do you like?
Vasculature-wise.
You want popliteal flow.
No. An open inline flow to profunda is enough to heal a BKA. So if you have a palpable femoral pulse, end of story. Because the pulse, if a femoral pulse is palpable, 99% of the time it has to be through a it has to be through a profunda. Most of the time, it's not. You can have an SFA open and distal open, and you might be lucky one that has a palpable pulse in the foot too, and you are doing a BKA for trauma or something else. But a palpable femoral pulse and an open profunda is enough to heal a BKA. Again, another misnomer. For a BKA too, for any major amputation, essentially, unless it is being complicated, there is no need to do any vascular workup most of the time.
Is that assuming it's chronic and they have maybe some gemiculates open, or even in the acute setting if they
In the acute setting too. The chances of healing in an acute setting, it's a good question. It's an excellent question. In an acute setting, the chances of healing a BKA with an absent, like if you have an acutely occluded SFA on the last gentleman who occluded his SFA stent, yes, the chances of healing that that BKA will be low. But again, if you are considering a major amputation, board does not want you to do extensive bypasses and extensive this and extensive that before doing an amputation. Okay. Key here is non-ambulatory. Key here is degree of tissue loss that we talked about, and this is the Rutherford 3 ischemia. Key here is a palpable femoral pulse, and if you have all these, you can go ahead and easily do the amputation. Amputations are considered minor and major amputation. This is how we vascular surgeons classify them. And minor amputation, I have a slide of that. Major amputation is above the knee amputation, below the knee amputation, through the knee amputation, and hip disarticulation. These are the major amputation to talk about. These are the minor amputation. If you remember this figure, you will never be confused about these foot amputation and all these names that they come on. There's a void amputation too. I don't have a picture of that. It's actually transcalcaneal, but transmetatarsal, Lisfranc, Chopard, and Siamese are the 4 foot amputations that we offer. Lisfranc, Chopard, and Siamese are not for people who are gonna extensively walk. And these, the Lisfranc, Chopard, and Siamese were great amputations in the past when the prosthetics were not so good. Now the prosthetics for the BKA are so good that the Lisfranc, Chopard, or Siamese, if you do one of them, they actually put the patient on a disadvantage. So now a lot of people would recommend do a transplant, and if the transplant does not heal, go to the below knee amputation because the prosthetics are great. Anyone who does below the knee amputation, I have the podium and I want to take it and I want to hammer it in your mind. Gone are the days when you check your forefinger and see and make your stump. Please do not make a stump which is less than 12 centimeters. The new prosthetic, it was excellent thing to do back in the day. Normally a 4-finger span in a normal person, unless you have big or wide hands, it's about 8 centimeters. Mine is about 7.5 to 8 centimeters. So if you guys check that and measure that and cut it off, and then you have to cut the bone about an inch proximal to it, you will be doing a stump which will be shorter, which is okay, patient will still walk on it. But if you want to give an option to your patient of those suction prostheses that are going to be sucked onto the BKA rather than hinged on the knee, and people use them for running actually, for competitive sports actually. I had a patient who used to run with those prosthetics. Then make sure that you make an amputation stump if you can. Most of the time you might not be able to, that's okay. But if you can, make it a little bit longer. So what I do is, I make my incision at 14 centimeter from tibial tuberosity. I actually take a ruler and measure it, 14 centimeter from tibial tuberosity, and then I go down to the bone and then cut the bone back by another 2 centimeters, so the bone is between 10 and 12 centimeters. And I was doing exactly the same 4-finger breath up until 1 year ago, until in our practice where I did my fellowship, we had a private prosthetist who used to work with us, and he actually one day came to me and said, "Why your stumps are too short, man. I can't do anything with them." So that's how I learned, and I worked into it, and he showed me, and I saw some of the prosthetics, and in this day and age, please make them a little longer. 10 to 12 centimeter length of the bone from tibial tuberosity is standard. Anyways, next question. An 80-year-old female, one more point about this is, if you have an elderly gentleman who barely gets out of bed, but they do get out of bed, they're going to go to the bathroom and that's about it, or they're going to just basically go from their bed to the couch, and go back from the couch to their bed. Chopard, Lisfranc, or Siamese are perfectly fine amputations. If somebody, they are not for people who are going to walk more frequently, but if there is somebody in your mind or in your clinical practice, I don't want you to just walk away from Lisfranc or Chopard. Not so much with Siamese, that's a little bit of more complicated operation, but Lisfranc or a Chopard can be easily done. And if you are considering somebody, rather than subjecting somebody to wear a prosthesis every time they get up, and they have to just go from there to there, Chopard is pretty good for them. Go ahead.
Just from boards, if they start asking about just straight amputation, you want to be on 3, do they want you to go ahead and say TMA on boards? Are they like?
If boards are not going to ask you that, but if you are amputating more than 2 toes, yes, the answer is TMA.
The scenario I think comes in a general surgery boards is a patient with a diabetic foot, which is a source controlled septic shock. So I think they won't go into the
No, they
details.
won't go into that.
It'll be just a guillotine source control and then go from
Yeah,
there.
for general surgery, it's invasive foot infection. You do a guillotine, take the foot off, and go on. Guillotine is very important for general surgery. This is just general stuff that you're going to use in your practice. 80-year-old female recently hospitalized for pneumonia and develops an atrial fibrillation. Whenever you feel in an exam scenario in your boards, an atrial fibrillation question, not an anticoagulation, think embolus. Think embolus to the SMA, embolus to the leg, embolus to the renal artery, embolus somewhere. 80-year-old atrial fibrillation. The following day, she complains of a painful right foot, which is cool and has no palpable pulses. After 4-hour delay, surgical evaluation is obtained. At that time, patient no longer complains of pain. A very important clinical part here, stating her foot is numb. Mild muscle weakness is also detected, and after bolus heparin refill, the next best step. What is the Rutherford category of this ischemia? Anyone can take a pick on it. 2B. 2B is the Rutherford category of this ischemia. Another thing, in acute phases, you're going to have pain in the foot, but as it progresses, you actually have sensory damage to the nerves, and then you might have some relief of the pain. If you have a relief of the pain, do not consider that this is intermittent claudication and the patient came in with worsening intermittent claudication. Almost nobody comes into the emergency room with worsening intermittent claudication. Let me tell you that. People don't like to wait in the operating room. People don't like to wait for hours and hours in the ER. So if they really don't have an acute ischemia, they usually are not going to come to the they're not going to come to the emergency room. Who's going to pick an answer on this? C. 2B ischemia, if you have sensory changes, if you have motor changes, 2A and 2B both actually. 2A is muddy water, but if you have 2B ischemia, the answer is surgical revascularization. It's not catheter-directed revascularization because the catheter-directed thrombolytics will take about up to 24 hours to open up that leg. In 24 hours, you will have blood flow but no leg. MRI of affected limb, it will probably happen next year. Percutaneous revascularization we talked about is not optimal therapy for 2B ischemia, and diagnostic angiography is not really required in an embolus case. As I said, whenever they give you a scenario of atrial fibrillation without anticoagulation and acute cold leg or acute mesenteric ischemia, think of embolus. Okay? And diagnostic arteriography is very important for completion angiogram, not so much for diagnosis. Next question. 75-year-old woman presents with the emergency room with severe pain in her right leg. She has a 60-pack year history of tobacco use and coronary artery disease, a prior MI, and atrial fibrillation. Physical exam reveals a palpable abdominal aortic aneurysm and a cold leg with paler port capillary refill from mid-calf to foot. Right common femoral artery has a bounding, strong, palpable pulse. Again, another important point and for question purposes. When they give you something as bounding pulse, they're not giving you a normal pulse. They are trying to give you a water hammer pulse. If you put a Doppler signal on this pulse, you will have no flow. It will be like, just because it is pounding against something and the artery is just open because of those circumflex iliac that we easily take. The artery is just open because some of the vessel is open there, a small branch. Otherwise, the artery would have clotted off all the way down to the level of iliacs or wherever the proximal endpoint, branch endpoint is. So whenever they give you normal pulses are usually not pounding, they are normal pulses. They're 2 plus normal pulses. We say pounding all the time. I just wanted to make sure that we do not confuse it because this is a misnomer that we use all the time, that the patient has bounding palpable pulses and we are trying to say they're normal. In question, if they have a bounding palpable pulse, it's actually an abnormal pulse. But there is no pulses distally. The left leg is normal. Most likely etiology of acute limb ischemia is, who's going to pick up on that? A. Okay. An important point in this case is the patient also has an aortic aneurysm. And you can think what Dr. Virk told you last time was that aortic aneurysm can also present with an embolic phenomena. So an important point here is most of the embolus are from cardiac sources most of the time. It's about 85% of the embolus are actually from cardiac sources. Another important differentiating point is that if you have an aortic thrombus or if you have a aortic aneurysm thrombus, usually the things that break off from aorta are not that big. They are actually small. So they will go past the bifurcation point of the femoral artery and go dislodge at the popliteal or go dislodge at the SFA distal, or they go actually into the tibial. They are so small that they will actually go into the tibial and lodge in tibial. So a blue toe syndrome is possible from an aortic thrombus, but most of the time acute limb ischemia with an embolus lodged at the common femoral artery is not usually possible. It's possible, but it's not usually the case in a aneurysm-related embolus. 85% emboli are from cardiac source. Contralateral palpable pulses favor an embolic etiology. So because peripheral vascular disease is most of the time symmetrical. So if you can palpate normal palpable pulses in the contralateral leg and you're considering an acute limb ischemia, most of the time etiology is embolus. And they'll give you points, and in real life too, there will be other things pointing out to an embolus as the etiology. Atrial fibrillation, not an anticoagulation, known previous ginormous aortic thrombus which was floating around. Those kind of things will be there to sort of give you a diagnostic point that this is a embolus and not a thrombus. If somebody comes into you who's got lifestyle limiting intermittent claudication, bilateral lower extremity for an upbeat years and has been worsening now, and all of a sudden now one of the leg is full, that is a scenario in which the diagnosis will be thrombosis, because they have an underlying peripheral vascular disease, and most of the time what happened is one of the plaque ruptured or one of the leg got ischemic because they acutely thrombosed overlying a plaque of one of their blood vessels. So pay attention to when this scenario says, when you are trying to differentiate whether this is an embolus or a thrombus. It doesn't matter from a sort of a dysentery standpoint. The dysentery will be still based on whether you are a category 2A ischemia, 2B ischemia, and whether you're going to do an open revascularization or you can do it catheter-directed thrombolysis, which is usually not going to be an option for you guys because it's a general surgery board, it's a general surgery question, and they're never going to ask you, most of the time, they're not going to ask you about catheter-based or advanced endovascular techniques. Okay? I think we'll stop here. I think we have maybe 2 more questions, but they are simple repetitions. Any questions that anyone has?